I'm Jake Lang, optometrist at Associated Eye Care in the east side of the Twin Cities Metro, medical director for dry eye services. And I'm joined here today with
Josh Johnston in Atlanta, Georgia, practice at Georgia Eye Partners.
Josh. When we're looking at patients preoperatively, or any patient we see in clinic, honestly, we're thinking about the ocular surface and keeping that as an important part of our patient's vision. In your clinic, what sort of things do you do preoperatively to help manage or screen patients for ocular surface disease?
Great question. We know it's part of the overall process, right? Best outcomes. We need to catch these patients and identify treatment options and do that. So we typically, for like a more esoteric dry exam, they'll go through meibography, interferometry. We look for MMP9 detection as well as osmolarity. That's sort of the dry workup.
Mm-hmm.
For our general surgical patients, we're typically just doing osmolarity and then, of course, looking at staining on the cornea with fluorescein and tear breakup time, maybe looking at the glands, that sort of thing, depending on what we see. But ultimately, if patients are symptomatic and we see it, or they feel it, or we see it, we're going to try to flag that patient and give them a treatment plan to help them with their outcomes.
Sure. So you're seeing a cataract workup, for example, and you're asking them about dry eye symptoms, not cataract symptoms. Is that right?
Correct, yeah. So we have some surgeons that are probably better than others at that,
Yeah.
We don't use a standard questionnaire. I think that's a good practice to do, and I think it'd be good to do like osmolarity on all of our cataract patients that are getting surgery.
Mm-hmm.
So we know the number one risk factor is age, and then gender number two with women. So we try to sort of, alert our staff, alert our doctors about these patients if we can catch them prior to surgery. Again, it's about helping them feel better, doing as much as we can on the front end so they have better outcomes. We know some of the literature now with light scatter, maybe 20 unhappy patients
Right.
there. The old days, it was about centration, and some of these high-end multifocals. We had a lot of dysphotopsias. The technology's gotten a lot better. However, a small subset will still be upset if there's some ocular surface issues there we didn't catch.
Right. And worrying about worsening ocular surface disease with any procedure, any refractive procedure, whether we're talking about LASIK, cataract surgery, glaucoma surgery, that controlled trauma surgery really might push them over the edge.
Yeah, we know from the literature, cataract surgery can increase the severity by one level, not as offensive as like LASIK or PRK, but we don't want to have that patient come back to us saying, you started my dry eye and made it worse by having surgery. So hopefully we can avoid that.
Yeah, we want cataract surgery or any surgery to be a good experience for the patient, not something that made something worse or that they feel like a failure occurred. Right.
Agreed.
Do you see a difference in cataract surgery and LASIK or PRK with regards to being a refractive surgery anymore?
It's very similar outcome. It's obviously a different process, but I think the goals and the expectation from the patient side are very similar, right? They don't know the ins and outs of what we're doing as a surgical team, right? As an optometrist co-managing them, giving them a treatment plan, whether they're undergoing PRK, LASIK, as you mentioned, or refractive IOL. The goal is to see well and see well after surgery and not have this be a big invasive process there. So we maybe proactively screen a little bit more aggressively for dry disease with refractive surgery on the cornea, but ultimately, most of these surgeries today in modern day are pretty good.
Yeah, the great outcomes, and that's what our patients are expecting, right? Is they're coming in expecting a refractive procedure, and we need to help deliver that. And ocular surface is such an important part of that.
Yeah, and there's really no excuse these days, right?
Right.
For 15 years we had one therapeutic. Now we have so many multiple concentrations of cyclosporin, lifitegrast, neurostimulation. We can go down the list of lid treatments there as well. But if you can identify these patients, we have much better opportunities to help them in their outcomes.
Yeah. So when you're seeing those patients and you may have a little yellow flag, I'll call it, or a red flag that there's some symptoms that might be related to dry eye disease, how do you examine the patient from kind of the outside in with regards to screening for some of the comorbidities and issues that we might see?
Yeah, so if I get a referred patient in prior to surgery, maybe that surgeon saw them for a consultation, saw a lot of staining or a lot of symptoms or using a lot of drops, whatever it is, that red flag was raised or yellow flag, they'll come in to see me, and then that is in a dry consult. So it mimics what we do for a dry patient. The surgical stuff is the same thing. Looking at interferometry sometimes, definitely looking at meibography, and then, of course, osmolarity and MMP9 detection. I will look at that data, then examine the patient, right? So look at the data, go into the room, have them look down, look for blepharitis on the lids, ultimately look for lag ophthalmos, micro lid exposure issues, anterior blepharitis, that biofilm on the lids, And then we start to push on the lids, looking at the quantity and the quality of the meibomian being produced, and then it goes to the ocular surface there. Is there mascarators, conjunctival chalasis, lid, ectropion? Is there staining? Do we need to address inflammation on the cornea? I think central corneal staining, big offensive thing for any type of modality, whether it's contacts, glasses, or surgery. We need to rehabilitate the cornea to get them better prior to surgery there for sure.
Yeah, those central staining patients, that can be a real challenge, and it makes you want to pump the brakes when you're doing that consultation, especially with the biometry, right? We've got great technology for biometry now with various ways of measuring the axial length and the corneal curvature. But if we don't, have good data going into that technology, we don't get good data out, do we?
Yeah, some of the literature recently has opened my eyes. We have really good technology measuring biometry, as you mentioned, even intraoperative wavefront aberrometry. And then sometimes we still miss. It may be a 20/20 patient, but now we're thinking about light scatter and just the tear film itself. It's a most important part of that refractive surface. We need to optimize that to help these patients. I think these patients, it's sort of counterintuitive. We view that as maybe 3 or 4 extra steps prior to surgery maybe, and seeing these patients a few times. They actually enjoy it. They like that. We help them feel better, help them with their outcome. And it's just a better overall patient experience when we get them feeling better and then ultimately improving their vision with what we can do.
Yeah. And I think it, reassures our patient that we're not just caring about their refractive outcome or, doing this refractive procedure, the in and out, so to speak, but we're actually caring about the whole eye and the health of the patient. And I think that really speaks home to the outcome and the patient experience as well.
Yeah, and again, it's kind of counterintuitive. We think, more is more friction, more process, more exams. Ultimately, we just find an overall better patient experience if we can do more of the whole process there. In the old days, it was diagnose a cataract, schedule for surgery, cut, and move on. I think with progressive modern refractive cataract surgery and all these other procedures, it's a slower process really optimizing every variable there.
Yeah. So you'd say that you'd rather spend more time on the front end, getting the patient ready for surgery, than in the postoperative period, spending extra time trying to undo what you've done.
Correct. It's an opportunity. We, in our Atlanta area, we encourage our affiliate, referring optometrists to take more of a job and take care of their patients prior to sending to us. And so some referring doctors don't want to, be involved in the co-management process. Sometimes commercial payers don't recognize these things and co-manage processes. There's an opportunity to see this patient 2 or 3 times. It's not about the process. It's about ultimately diagnosing dry ocular surface disease and dry eye, treating them to hopefully see that and get it better prior to coming to us for surgery.
Yeah, and how do you feel like that affects chair time? Chair time is so important. We're all, very busy and things like that. So, chair time with these patients and in the postoperative period versus the preoperative period and how that affects your clinic.
Yeah, I think my mindset there is, you're the expert. These are your patients. Don't just diagnose and refer and dump them. 20 years ago, Mrs. Jones, you have a cataract, you're going to go see Dr. Smith down the road. I'm done with you. You'll come back to me when it's over. Now, especially optometry, we're more involved in medical optometry, doing more of the frontline stuff, diagnosing and treating these options there, conditions. And again, it's just you're more a part of the partnership and process through the patient care than we used to be 20 years ago for sure.
Yeah. Great. Josh, let's talk about some cases. So you're seeing these patients, and like we said, we're working from the outside in. Say you see a cataract consult, and that patient has a ton of, anterior blepharitis, from different pathogens, whether it be Staphylococcus or Demodex or something. There's something going on in that anterior lid that you don't like. You're saying, hey, I got to pump the brakes here. We got to treat this. I got to get you ready for surgery. What is your favorite modality of improving these patients in that perioperative period?
It's such a common thing we see, right? And this is a chance to really pump the brakes, give them a proper diagnosis and treatment plan there. So we want to maximize the lids and all this stuff. Maybe it's not as critical as the ocular surface. Maybe it is. It just depends on the symptoms of that patient. But if we can slow things down, if we see anterior blepharitis, hypochlorous acid is my go-to treatment for that sort of staph, biofilm, lid issues there. Sometimes we do microexfoliation and debride the lids to get them feeling better. And then, of course, have them look down. We have all these sort of over-the-counter products with tea tree-based stuff. We're looking forward to new therapeutics that will really help eradicate that disease state, such as Demodex. Right. So it's exciting times. It's an opportunity to catch this, clean up the lids, ultimately helping these patients feel better prior to surgery.
Yeah, these external pathogens, the one nice thing is hopefully we have some ways of managing bacteria and hopefully have more ways of managing pathogens in the ocular surface soon.
Absolutely.
All right, Josh, let's talk again, moving our way in. What about MGD? MGD is obviously a very common and maybe the most common contributor to ocular surface disease and dry eye. So a very common thing we'll see in those perioperative patients. You see a patient with a lot of MGD, really insipated glands and horrible meibum. What's your go-to for treating those patients?
Yeah, I've become a big believer in mybography, right? To kind of catch these patients, we see that when sometimes there's all complete gland loss and atrophy. You press as hard as you can or even do expression and nothing comes out. So we want to avoid that, right? So ultimately helping patients feel better, catching them and diagnosing them. So we'll do mybography, and then of course we'll express glands, looking at the quantity and the quality of the meibum there. Oftentimes we'll do a lot of thermal treatments prior to surgery there. Again, helping patients. They like this journey of being diagnosed with something, giving a treatment option which 20 years ago we would ignore. We would just refer for surgery. The surgeon would cut. They may be a -1 residual refractive error. That was okay. Even monofocals now, no out-of-pocket expenses, they're really aiming for 2020. That's the expectation. It's that LASIK generation that drove that wants that good outcome. If we're not looking and treating MGD, you're certainly going to have a higher risk of residual refractive error and just unhappy patients there.
Thermal therapies are definitely a great option for our patients. What if there's a lot of, I'm in upper north and Midwest, we have a lot of rosacea patients. Do you feel like that really contributes a lot to meibomian gland disease?
Yeah, it's been fun adopting IPL in our clinic in the past year. Myself, we've had it in our group for about 10 years, but doing it myself for the past year. We see ocular rosacea. What is that? There's no definitive test. When we see those telangiectasia blood vessels feeding inflammation to the lid margin, the side effects, we can kind of make our patients look a little better, right? Take care of some of the wrinkles, but ultimately it's about treating inflammation to the lids, helping on obstruction, coupling that, usually 3 or 4 treatments, finishing up with a thermal lid treatment there to really treat inflammation and then work on obstruction next. If you can do those 2 things, not everyone, but most patients benefit and get better from that.
Yeah, that's a great point. Treating the inflammation and rosacea being really a sign of inflammation. That's huge. That's important. So I love that plan. Treating the thermal pulsation on the back end, really helping that. And how many patients do you see after cataract surgery say, oh, I didn't know I had so many wrinkles? Well, maybe you have the added benefit of maybe minimizing some of those, so they're not so surprised when you give them that perfect 20/20 vision back.
Yeah, it's a fun, they see pingueculas, whatever, everything they didn't notice, they start looking at their eyes in the mirror after surgery, and some of it's because we did it, they think, or they just noticed the wrinkles, like you said. So it's a fun conversation.
Yeah, great. And great technology, right? We've really advanced the options for our patients. We need to deliver on those.
Absolutely.
All right, Josh, I'm going to give you a tough one here. Now, we have this patient that comes in, and we're looking to help them get through cataract surgery. It's an older patient. They have a history of autoimmune disease like rheumatoid arthritis and Sjogren's syndrome. So some of our more severe dry eye and ocular surface disease and some obvious signs, obvious symptoms. This patient's been dealing with this for years, but now it's time for them to have cataract surgery. What do you do to take care of those more severe aqueous deficiency, autoimmune related dry eye patients?
I call these a real dry eye patient. I sort of joke, but we have 4 optometric residents every year, and then externs that are coming through. And I try to grab them and say, look, this is not like a 25-year-old complaining of a flare and going to Las Vegas. This is a autoimmune disease, real dry eye patient. And what that really is the kitchen sink, right? So we need to suppress inflammation, work on that. T cells life cycle is about 90 to 110 days. So if we can suppress that tear film, the inflammatory T cells and activating those cytokines, work on increasing natural tear production. So we have 3 sort of immunomodulators these days that are FDA approved, a few more now that are FDA approved recently, which all have access to, a new category of neurostimulation. We can work on increasing natural tears. And then if it's a real Sjogren's patient, right, there's a lot of staining, sometimes filamentary keratitis. We're going to look at things like autologous serum, punctal occlusion, and of course amniotic membranes there just to rehabilitate the cornea. Probably the quickest thing we can do to help those patients on that journey. We're going to prescribe a lot of medications, as we mentioned, but maybe an amniotic membrane or serum is going to be needed, biologics, that sort of thing.
Yeah, it's the kitchen sink there. I think that's a great point, and really giving them some sort of production. Little improvements make a big difference in some of these patients. But protecting the ocular surface and really rehabilitating as much as you can before surgery is so important.
Yeah, those are my favorite patients we catch, right? They've been drifting through clinics for years. Now they're having surgery. They're not going to get premium technology if they have a diffuse punctate keratitis or filamentary keratitis. Maybe they're okay with a standard monofocal or some of the newer technologies we're using. but we can help them feel better, give them a better treatment plan than just like palliative tears they've been using for years with really no focus on that disease state.
Yeah, kill two birds with one stone.
Exactly.
Yeah, great. Well, thank you. It's been a pleasure to work with you, Josh. It's always fun to chat eyes with you, and such an expert. We look forward to what's next.
You bet. Always fun to be here and learn something from you as well. I appreciate the opportunity.
Thank you.